and welcome to the Research Works podcast, brought to you in association with Curtin University and the Healthy Strides Foundation. Your hosts are Dr. Dana Poole and Dr. Ashley Thornton, and together we will interview world-leading researchers in the area of child health to support your practice in being more evidence-based.
Hi, everyone. Hi, Dana.
Hello, Ash. It's great to be here again.
So great to be here. We have a wonderful article to talk to you all about today that is titled Deep Brain Stimulation for Cerebral Palsy. Where are we now? This was actually an invited review that was published in 2019 in Developmental Medicine and Child Neurology. And we are so lucky to have the author, Dr. Terence from the Children's Hospital Orange County, joining us on the show today. Welcome, Terry.
Welcome, Terry.
Well, thank you so much. It's a pleasure to be here.
We're so excited to talk to you.
We really are. Look, for a bit of background, Terry is someone that I met over 10 years ago now. That makes me feel a little bit old. But it was the Oz ACPDM in Brisbane, and he was the invited speaker there, the platform or keynote speaker is what they call them.
Yeah.
Yeah, it's a pretty cool position to be in. And he spoke about all things hyperkinetic movement disorder and dystonia, and I learnt so very, very much from him. He's also got a whole lot of other skills as well. So we actually talked a whole lot about neuromodulation, the science of casinos. I think that's a really cool area.
Yeah, I'm interested.
Music, the banjo, and how to function on very little sleep. And of course, all things of the brain. So yeah, I feel like that's a really long time ago now, Terry. Do you remember that? It was 10 years.
I do remember that. I did not remember that it was 10 years ago. Feels like less than that. So thank you for reminding me of the passage of time.
Well, Terry, the article that we are going to talk to you about today is a little bit different. And for our listeners, it's a bit different in that it's not a study as such, but it was actually an invited review. So this occurs when experts in the field are invited to summarise the state of the evidence and the current clinical applications of our knowledge. So basically what that means is that Terry is super knowledgeable in the area of deep brain stimulation, which is the topic of this review. And we know that families do spend a lot of time searching and researching on the internet, and deep brain stimulation is something that comes up in those searches often. Yeah. So it's really important that as clinicians working with families in the community that we have an understanding of what deep brain stimulation or DBS is, when it might be indicated for use, and what the outcomes might be, because as you'll hear from this conversation, it's a really exciting area, but it needs a lot of careful consideration from multidisciplinary teams.
Yeah. No, that's a really good summary.
Yeah. So to tell you a little bit more about Dr. Terry Sanger, he's a physician and researcher and is also the Vice President for Research and Chief Scientific Officer at the Children's Hospital Orange County. He's both a neurologist and engineer, having received a bachelor's and master's degree in applied mathematics from Harvard University and a doctorate in electrical engineering from Massachusetts Institute of Technology. It was after this that he started medical school at Harvard Medical School. Dr. Sanger is really well known for his extensive experience in pediatric neurology, movement disorders and robotics, and his publications certainly reflect this.
It's pretty impressive, really, isn't it?
So impressive.
Terry, you must get this reaction all the time. I mean, we had to put in there Harvard and MIT because I think that's kind of cool.
Yeah.
But you must get this reaction all the time from the multiple degrees that you have.
Well, I was very lucky. I mean, these are great institutions, but the most important thing is they're great institutions with great faculty in them. So I learned from some spectacular people. I mean, I had the opportunity to learn control theory from Roger Brockett and to learn neuroanatomy from N. Graybiel. I mean, these are just leaders in their fields. So I'm very, very thankful for that.
Yeah, I think the combination is amazing, really, both engineer and in terms of medical. And you can see that with regards to your robotics work.
Yeah.
But yeah, I think we should get to know Terry even more.
Absolutely. So to help our listeners get to know you a bit more, Terry, we'd like to start all of our podcasts with a little icebreaker question. And today the question is, if you had to teach a class on anything besides topics related to your profession, what would it be?
And that's a very tricky question because, of course, I don't like to teach about things I know nothing about. There's always learning on different things. But I've become very interested in the origins of language and the ways in which language could have evolved very rapidly in only a single species. And so maybe I would teach something about that, about the relationship between many of the theories of linguistics and linguistic development and evolutionary linguistics, which is not an area I know that much about, but thinking about the computational neuroscience of the development of language, which is an area that I also know nothing about, but at least know something about the edges of. So I think that would be a lot of fun.
I would go to that class.
Yeah, that sounds very, very interesting. What about you, Ash?
Oh, look, it's hard to follow up that answer. I could probably teach you a little something about horses. I grew up around horses. I know quite a bit about horses. I also, having a 3-year-old daughter, know a lot about Bluey, which, Terry, you might not know is quite a popular children's program here in Australia. I'm well versed across Bluey at the moment.
I think there's many parents out there will just be nodding their heads right now as they're driving their cars going, yeah, I know all about that.
I quite enjoy it myself as well, to be honest.
No, that's really cool. I think this is such a great question because it does make you think about other areas that you're interested in. And I'm hugely into music. Like I do love music, but I often just don't have the time to dedicate to it. And it's one of those things, I'm one of those people where you're either all in or you're out. Like if you can spend all your time being really good at something, that's me.
Yeah.
I can't quite handle just being middle ground. So if I had to teach something else and just do it, I just do music. Just music in general, like just classical or pop or writing.
A music appreciation class.
I think so. Yeah. I think that'd be really, really cool.
I'd go to that class.
Yeah. And like what music you listen to if you're studying, this is PhD music, this is angry music.
If you recall, Dana, many years ago, we had a soft competition to see which of us could learn the Pathetique Sonata up to speed first.
Well, I do remember that, and I didn't get quite up to speed for that one.
I didn't either, but it was fun to try.
It was really hard. Yeah, I think we got up to maybe a 4th page, and the metronome speed, I can't remember, but it was something wild, like 180 per quarter note or something. I don't know.
Oh, my goodness.
With lots of semiquavers through it. So, yeah, I do remember that. Thanks, Terry.
All great answers. But let's get into the article. So, Dana, could you summarise this review for us?
Absolutely. Well, as many of you listeners might recall, we actually spoke to Dr. Boomer Aravimuntham not so long ago about dystonia and cerebral palsy. And there was so much interest in this topic because dystonia and cerebral palsy is an impairment that has a profound influence on function and is actually such a challenge to treat. And a lot of this is due to both the definition of movement disorders and the identification of movement patterns. And deep brain stimulation, or DBS, is often an intervention we hear alongside dystonia within the broader medical management context. So DBS does require neurosurgical procedure and has been used for the best part of 40 years now, with modern technology improving both the safety and the efficacy of the procedure. So with current knowledge, the questions are, what is DBS? What does it achieve? Who is it best suited for? And what is in the future?
Thanks, Dana. And before we get into some of those really big and important questions, Terry, it seems like it'll be important to ensure we're all on the same page when it comes to some of those definitions that we're going to be covering today. And we know that you've led a large task force coming to a consensus around some of these definitions. So we were hoping that to start with, you might be able to talk us through some of them and to broadly, we talk a lot about positive and negative motor signs. So we thought we might start with the negative signs and what they are.
Yes, certainly. And I don't have the original consensus papers in front of me at the moment, so I'll do this as best I can from memory. We took an analogy from the world of psychiatry, where you talk about the positive and negative features of psychiatric disease, where the positive features is where there's sort of too much of something, and the negative features is there's too little of something. So you could have a psychosis being excess inserted thoughts, or you could have a depression with sort of decreased activity. And these are that's an older terminology, but it was a helpful terminology in the world of psychiatry. And so we borrowed from that to try to say, well, is this a reasonable way of creating an initial taxonomy for movement disorders? Because there's clearly some movement disorders where you have too much. There's a tremor, there's a stiffness, there's a spasticity, there's sort of too much muscle activity. And then there's other movement disorders where you have too little. Your weakness would be the obvious one, no less activity, but it can be more complicated than that, such as lack of coordination, lack of motor planning, so lack of praxis, or lack of balance. So it's the inability to do something. And I think the reason that distinction between sort of positive and negative symptoms is so helpful is because if you think about it, almost all of our medical and surgical interventions only affect positive symptoms. I can't give you strength. I can't give you coordination. I can't give you skill. That's the realm of rehabilitation. That's the realm of practice. That's the realm of coaches. But I can take away excess muscle activity, whether it's through things like botulinum toxin injections or by modulating stretch reflexes. I may be able to remove the signals that cause dystonia. I may be able to dampen down a tremor in some way. So there's this big difference between sort of the medical surgical interventions and the rehabilitation interventions, which approximately divides along the line of positive and negative symptoms.
Wow, that was actually a really good summary of how to think about positive and negative. Thank you so much for that, Terry. So I guess if we're talking about the positive signs, I know that you sort of separate them into two groups. You've got, the positive signs that affect posture, and then you've got the positive signs that affect movement. Can you talk us through the distinction between the two of them?
Yeah, I think when we first set out to do dystonia, one of the most obvious features of dystonia is that people are stiff. That's also very common in Parkinson's disease. There's the sort of the rigidity associated with Parkinson's, and there's the stiffness associated with spasticity, and so this is this idea of hypertonia being the stiffness, and hypertonia. It's a very funny thing because often the patients themselves, the children that I work with, they won't complain. They don't come in saying we're stiff. The parents might say that I can't change their clothes or something, but the kids don't complain about that particularly. So it's stiffness. Hypertonia is something you from the outside see. When I try to bend their arm, I can't do it. They may not actually be strong. Their muscles may be stronger than me, but they're not overpowering me because they may not be able to move either. They're stuck often in a posture. So that's sort of the hypertonic component to it. But you can also have too much movement. There could be a tremor or an excess movement. You move towards something and your arm shakes around in some way. And so that becomes hyperkinetic. And the reason this was important is because every time we tried to define the concept of dystonia, we recognized that dystonia actually had both. It lives in both categories. Most things live in one category or the other. Tremor is hyperkinetic, but is not hypertonic. There's nothing about tremor that makes you stiff, right? And spasticity is hypertonic, but it doesn't make you move more. If I test your reflexes, the reflexes may be high, but the spasticity itself doesn't make the child necessarily move more. So that most things are in one category or the other. And dystonia was interesting because it sort of lived in both, and it became important to try to separate those things.
So that's really interesting. When we talk about dystonia, then we do talk about how it affects movement and posture. Maybe for like our sort of level of neurology, what's the main sort of mechanism behind that? I mean, we always know that, basal ganglia is what we talk about for it, but it's sometimes a lot more than that too, isn't it? It's like there's the inputs in and out of basal ganglia. Can you talk us through that, like in brief?
Well, I have to say, I mean, that's the $6 million question. I mean, and really, I've dedicated my research life to try and answer these questions. One of the things that has become clear over the past few years, and we can talk about this more in the context of deep brain stimulation, is that hypertonic components of dystonia and hyperkinetic components of dystonia probably are not the same. Originally, we thought that the difference is if you contract your biceps and triceps at the same time, you get stiff. If you contract them at different times, you get movement. But it doesn't look like that. And the reason I say that is because when we use DBS in different targets, we get different effects. So a deep brain stimulator lead in the internal globus pallidus has much more effect on hypertonia, on posture, whereas a deep brain stimulation lead in thalamus has a much greater effect on hyperkinetic. And you can really treat one without the other. So we call them both components of dystonia. But in fact, it may be that they're both components of cerebral palsy. and that that they go together because these are two brain areas that structurally are susceptible to similar kinds of injury. So, for instance, in some of the genetic forms of dystonia, you don't get nearly as mixed a picture. So DYT1 dystonia, one of the more common genetically identified causes, tends to be primarily hypertonic. When there's components to it that appear hyperkinetic, it's usually because of people fighting the hypertonia. So the kind of choreoathetotic hyperkinetic movements that we see commonly in children with cerebral palsy are reasonably specific to cerebral palsy, to the point where you can sort of recognize the disorder in some ways. So I think these may be different. So that's just the preamble to your question, which is to say the answer is going to be different for the two different pieces to that. I can tell you my guesses on this, but none of this is proven by any means. It looks to me as if the hypertonic component, so in order to be stiff, you have to resist movement. Movement is not resisted by co-contraction. Movement is resisted by a muscle contracting against you, the examiner. So if I try to extend the elbow of a child with hypertonia, their biceps contracts in order to resist me, in order to try and hold that posture. This happens in Parkinson's disease, it happens in dystonia, and it happens to some extent in spasticity. So it has to be a reflex mechanism. So and my guess is that, when you look at the timing, it's long latency reflex mechanisms, which are probably a combination of polysynaptic reflexes in the spinal cord, as well as reflexes that are going up through cortex. And so somehow those reflexes are being turned on involuntarily. It's probably not a change in threshold, which is more characteristic of spasticity, where you have a threshold effect. It's probably a change in the actual in the actual gain of that reflex circuit. One of the interesting things about hypertonic dystonia is that you can usually mimic it. So healthy people can mimic that, whereas healthy people usually cannot mimic a spastic catch. This suggests that it may be the same postural mechanism. So dystonia may co-opt the normal mechanism of maintaining fixed postures, which probably involves long latency stretch reflexes. That's how you resist being pushed off balance, or being, if you want to hold your arm in a position, you do it a little bit by co-contraction, but co-contraction really just causes viscosity. It doesn't hold postures very well. So a lot of that is going to be done by engaging these long latency stretch reflexes. So dystonia to some extent takes over the normal postural mechanism. Now, whether that's coming from basal ganglia, I don't know. I don't think it has to come from basal ganglia. I think it can come from many different brain areas, probably just driving probably cortical areas that are responsible for holding posture. That's my guess as to the hypertonia. For the hyperkinetic components, that's a very interesting one because they look very random, but I don't think there is such thing as randomness in the brain. So that if there's something that looks random, it's generated, I think it's probably generated by the environment. So I think the hyperkinetic component is an inappropriate link between irrelevant sensory inputs, wind blowing across your skin, pressure on some other part of your body, something you heard or saw. Those inputs are somehow inappropriately hooked up to the motor outputs and are not filtered properly. So it becomes a lack of filtering in something that might be much more of a dynamic control, so that there are probably circuits, most likely thalamocortical circuits, that are responsible for the dynamics of movement. These circuits are probably normally engaged by certain types of sensations, and that somehow you're not filtering that properly, and you engage those sensations. So I suspect that's what's happening there is when basal ganglia are involved, they are not suppressing irrelevant dynamics, and they're not again, dynamics are going to be the relationship between the dynamics of sensory response and the dynamics of motor output. So if those are not being suppressed appropriately by components of basal ganglia, then you can see essentially a release, probably somewhat similar to what we see in chorea, when there's when you have injury to the subthalamic nucleus and you have essentially release of little movement fragments. But again, this is all very much guesswork. These are the hypotheses I'm currently testing.
And I think when you talk about that, I can already imagine the patients and the children that I work with when we talk about the dyskinetic elements where you see a lot of these hyperkinetic movements. I know that if I were to position the child in a certain way or my hand leans in a certain way, you do get, this excess movement. And at times it's predictable because you know what sort of sensory inputs or environmental stimuli might cause that, but you do definitely see that. And I think that's why when you talk in your previous papers, we talk about dyskinetic cerebral palsy. We say that because there's elements of dystonia and chorea and athetosis. There's usually like a blend of the three. Is that right? That's how we see it?
Yeah, I think sort of choreoathetosis, dyskinetic dystonia or hyperkinetic dystonia is a thing that can exist by itself. But I think in when cerebral palsy is caused by an acute hypoxic ischemic injury, that will typically affect multiple areas of the brain, both thalamus and pallidum. And probably it's the combination of the two injuries that leads to the two different components of the dystonia that we see. So it may not be because they share a common neurophysiological mechanism. It may be because they share a common injury mechanism. And that may be true even for many of the metabolic disorders. We will see this in glutaric aciduria, for instance. Whereas in some other ones, pantothenate kinase deficiency, you tend to get much more of the hypertonic component with particular sort of predilection for proximal musculature. There's other components in Lesch-Nyhan. You can see the dystonia, but it seems to be associated with a tic disorder and with compulsions and with reversal of volition. So there are these very sort of characteristic injuries to these areas, which probably lead to multiple sort of functions being co-opted in some way. But so I think when we're looking at cerebral palsy, which is has many different causes, it has many different causes, but there are predominants, right? So when we're looking at the dystonic or dyskinetic primarily form, you're looking at children who came near term and perhaps had an acute hypoxic ischemic injury at that time. And so I think that is going to have a very characteristic pattern of injury, and that's probably what we're seeing.
Specifically about a deep brain stimulation now, as we understand it, and my understanding is minute compared to yours, it's a neuromodulator. So could you explain to us what that means and how it has been used in pediatric populations?
Yeah, I think the this tendency to think from the science fiction point of view. I'm putting wires into your brain. I have control. I have total. I can put thoughts in. I can read your memories. I can do all of that. And it's important to realize that we have typically 4 wires, each with 4 contacts in there. So I've got 16 wires in your brain, which has, 100 billion neurons in it and, 10, 20 trillion wires in it. This is sort of undersampled, right? I mean, the scale is massively off. And the analogy I often use with the medical students is it would be like trying to repair a computer using a hairdryer. You can point the hairdryer at different parts of the computer. And in fact, that may help it. You may warm up part of it and you may cool down other parts of it. And that may be helpful. But you're nowhere near the scale of the integrated circuits that are actually doing the processing. And so it's more anatomically precise than giving a medication, which bathes the entire brain. So medications are sort of physiologically precise. They're chemically precise. They will target a particular cell class, a particular transmitter class, a particular cell receptor or membrane receptor, but over everywhere that those things exist. A deep brain stimulation targets anything that's electrically active in a fairly large region. Typically, tens of millions, possibly to hundreds of millions of cells are affected. And which cell classes are affected is going to depend on their membrane excitability and other things. So it's not a huge difference from what happens with chemicals. So when I use a medication, that's a neuromodulator too. If I put in a benzodiazepine, that is modulating the excitability of membranes for anything that has a benzodiazepine receptor on it. If I put in levodopa, that is also modulating the excitability of cells and the ability to transmit between cells for anything that can respond to levodopa, that can absorb that and release dopamine across synapses. And when I put a deep brain stimulation electrode in and activate a voltage on it, it also is in a localized region going to activate these things. So it's anatomically specific, but in a very, very broad sense. I mean, these things are literally cubic centimeters of brain tissue can be activated.
Yeah. And so what helps you or what information do you use to make a decision about where to target the stimulation?
So in some cases, there's tremendous information in Parkinson's disease in adults of what the targets should be. There's a lot of information in, I mentioned DYT1 dystonia. We know where the targets are. In fact, it probably doesn't matter that much. I sort of joke that you can put a wire sort of anywhere near the basal ganglion. As soon as they smell it, they start to get better. Again, but the point is that you don't have to be quite as accurate. But when you're dealing with secondary dystonia, it's an acquired injury. So even though there are brain areas that have a predilection, no two children are the same. And we all know this as clinicians treating these children. No two children are the same. They have different balances of different deficits and strengths. And so I felt early on that the reason that we weren't getting very good results, and for a long time, the statistic was about 50% of children with secondary dystonia would receive benefit from DBS. I felt the reason we weren't getting good results is that we were putting the leads in the same place in all these children as if all the children have the same problem, which they don't. And so I had actually started a different way of looking at that, which I do describe in this review. Again, it's supposed to be a review of other people's things, but I also, of course, review some of the way I do it. Which is I borrowed a technique from the epilepsy people, which is that they don't if in epilepsy surgery, often they're cutting out a piece of the brain. And you're not going to cut out the same piece of the brain in all children. That would not be a very good idea. So what they do is they put depth electrodes in. They try to figure out where the seizures are coming from. And then they cut out the part of the brain that your particular seizures are coming from. Now, we're not cutting out parts of brain. We're putting in electrodes. This is a reversible procedure. But you only want to do it once. So we put in depth electrodes. And I joke that they're a little deeper than where the epilepsy people go. But we put depth electrodes into multiple possible targets. And we test them. And we turn the things on and we see what happens. And we can also listen. So we can hear where the dystonia is coming from. And then, of course, the research information we gather from this is huge as well. And this has been, we're getting in the secondary dystonia, we're getting about 90 to 95% success rate. And again, I think there's two reasons for that. One of which is that we can customize the targeting to individual children. The other reason is that we're going into thalamus as well as basal ganglion. I think thalamus is a huge win. I was saying before that the hyperkinetic components respond to stimulation in thalamus. They almost always respond to stimulation in thalamus. If you have hyperkinetic components to your dystonia, I can almost always stop it, to the point where if we put wires in and we don't, we'll take those wires out and we'll put them somewhere else, because it's very reliable in the secondary dystonias. It's much harder. The hypertonic one, I still don't think we found the right target. I think pallidum is good but not great. But thalamus does work. The problem is it's different parts of thalamus for different children. So you do have to do this. But with that, you make it so basically I don't know ahead of time. We try it and we see. Mm-hmm. And the nice thing about this is when you put the temporary wires in, we wake the children up. Like, we put the wires in and they're coming out of their head, but that we bring them up to a hospital bed and they can move around. We have children walking while we're stimulating different parts of their brain, and they're talking and eating and doing whatever it is they're able to do, and their parents are watching the whole time. And we can ask the parents, is it better or worse? Is it good enough? Is it not good enough? And at the end of a week of all this testing, we ask the parents, look, you've seen what we can do. You've seen maybe it'll be at least this good. Do you want to go ahead with permanent wires? And if they say no, everything comes out, kid goes home, they're fine. But if they say yes, then we can go and put permanent wires. And we've only had I think we've now done 35 children this way, and there's only been one where the parents elected not to proceed with permanent wires.
Wow. I mean, that sounds so similar to, my experience with, ITB pumps, and you do have that sort of temporary, and you can see what sort of effect it is, what the outcomes were. It sort of measures your expectations, I suppose, and then you go for the more permanent. So in terms of what sort of ages and GMFCS levels have you seen and range? Can you give us a bit of a rundown on what that looks like?
Yeah, so I think the youngest we've done is 5. I think the youngest worldwide is maybe 3, or someone did a late 2s. We could go there. I feel like it takes a while for dystonia to declare itself fully, and then it takes a while for you to try the medicines, and the medicines often work more effectively in the younger kids. So I think it's going to be unlikely we'll go much below 5. I think we've gone down to 5, not with this technique. In terms of, and oldest is up to 21, just because, we're a pediatric hospital but I do have like 23, 24-year-olds who want this. For instance, people with we've done this in Tourette syndrome, and it's the same kind of thing. You have to probe around in Tourette's. But it does look like it makes a huge difference. So there's an adult category that wants, so we're trying to find adult hospital partners that can work with us on these techniques. I have some. In terms of the categories of children, when you only have a 50% chance of success doing elective brain surgery, you're going to go for your GMFCS5s. You're really going to be looking for kids who really have no other hope, because it becomes heroic. Once you have a 90 to 95% chance of success, you can go for less severe kids, because you're more certain. Now, it's not 95% in every child. In other words, I'll give the parents lots of ideas of what can you expect. You could have a contracture, you could have significant cognitive delays. There's lots of reasons, other things that may limit your function. But the question is, if dystonia is the limiting feature, or limits your abilities in some way. So that's the first thing. You have to say there has to be. If I could get rid of 100% of your dystonia and it wouldn't make your life any better, then there's certainly no point in doing this, right? So dystonia has to be an impairment that's having an effect on your life that's important. And then you have to say, okay, what do you think? What are the risks? If a child has significant brain malformations that would make it hard to do this in some way, if the child has a particular risk of or prior history of infection, if there's something else that makes us concerned about this, they live too far from a center where we could manage this, there may be other things. But beyond that, I really feel like, since you can try it, if the parents say this is bad enough that we're willing to do elective brain surgery, that's the criterion, right? I mean, I'm not gonna judge. I'm gonna give them all the risks. I'm gonna give them the possible benefits and understate that, and then say, what do you think? And then we can try it. And then they can see. And again, it has to be enough of an effect. We've done kids who are ambulatory, but didn't walk well and just wanted to walk better. And we've done children who are just really have very minimal cognitive function, very almost no voluntary motor function. But they were so stiff that it was very hard to care for them, get them in a wheelchair or get them in a car seat. So there's lots of reasons why removing dystonia could be helpful to the child or to their family.
And so just going back there in terms of the risks, are there any risks for, like, if a child has a history of epilepsy or seizures? I mean, that's the part where my brain goes to if we're thinking about doing something like this. Have we seen any effects on that? Actually,
the only effect we saw is we had one kid where we put the wires in, and he came back a couple months later to a follow-up visit, and just talking to them. I was like, okay, what medicines are you on? And the mom listed the medicines. I was like, and of course also the levetiracetam. She's like, no, I took him off that. I was like, what? And she's like, well, he hasn't had any seizures. He used to have 5 seizures a day, but he doesn't have them anymore. So deep brain stimulation does seem to be effective for seizures. It depends on where you go. In his case, his dystonia was well treated by a lead that was in more anterior regions of thalamus, which is one of the areas that's known to treat seizures. So we have certainly never worsened seizures with this. I think there's going to be a category of children who have both dystonia and epilepsy. And in those children, it may be worth literally doing both procedures at the same time. So you drop the epilepsy depth electrodes which are the same as the deep brain stimulation, the movement disorders depth electrodes, and you just probe those areas at the same time. It's the same equipment.
Oh, Terry, we could talk to you about this all day. There's so many questions that we have, but we're really mindful of the time. So I just wanted to kind of finish up our questioning around this idea that you talked about in the review of the role deep brain stimulation might play in plasticity, and the impact that it might have on, potential surrounding tissues that are uninjured to start with.
So one of the big conundrums of deep brain stimulation is that it doesn't work right away. So you can put leads particularly into the internal globus pallidus, and you may see changes within minutes or hours, but the full changes can take weeks, and in some cases months or years to see the full effects. Everyone sort of assumes that's due to plasticity because nothing else seems to operate on that timescale, although it certainly hasn't been proven. Interestingly, thalamus doesn't do that. Thalamus, you put in, you see the effects right away. So this suggests that the mechanism of action of DBS in GPI is as a plasticity modulator, whereas in thalamus, it may actually be an activity modulator. I don't know that for sure, and probably it's all going to be mixed. The other thing that we've noticed in children, which is very different from the adult world, if you have an adult and you put in DBS for Parkinson's, you find the right settings, you leave them, and they come back in a year, and it's still the right settings. Children change. We have to program them every 2 weeks, and it's following. And something that works now might not have worked a year ago, and something that worked a year ago may not work now. Their brains are continuously changing, which makes sense. I can't put 5-volt signal at 185 hertz into the brain of a developing child, and expect that it's not going to have some kind of effect on plasticity. It's scary because we don't understand it. It's scary because what if it's not reversible in some sense? But I think it is the mechanism of efficacy. And so we just track it and we follow it, and you just have to be willing to continually make changes and recognize that the brain will adapt in both good and bad ways. Sometimes it will adapt to work less well, and then we have to change things to make it more. And I will actively sometimes program in ways that are intended to avoid plasticity. Like we'll tell the parents, turn this off overnight, or we'll have the machine cycling in some way to try to reduce the brain's ability to adapt to it, because maybe we have a good effect, and I don't want the brain to start ignoring it by its plastic phenomena. It's not well understood at all. I mean, this is all empirical. And it's different in every child.
I guess there's a lot of exciting opportunities to be looking at this for future research. Look, I think just to summarize this amazing conversation that we've had so far, and I wish we had so much more time, but I guess for all of our listeners, I think it's really important to get your hands on this review, to have a read of it, and to get the information in there. I think it's really important to know what the definitions are, to be able to identify the difference between, what's primary and secondary, know what we're trying to treat, but also recognize the role that we might have to play in the grand scheme of things with regards to providing support or identifying the features that may benefit from these sort of treatments. But at the end of the day, it's a big multidisciplinary team. It's Terry spoke there. It's not just about the ability to improve function for walking, but it's also care and comfort. It's your GMS level 5s. It's looking at the possibility of success rates, and I think that's something really worthwhile just thinking about and helping parents to understand that within context as well.
Yeah, and increasing your knowledge base so that you can have those conversations with families. That's really important.
Yeah. Well, thank you so very, very much, Terry, for your time today. We have absolutely enjoyed the conversation and just being able to just review neuroanatomy and understand, mechanisms, and, those things are actually so important. And I think that brings it to light today. So for all of our listeners, remember you'll see the show notes and the run sheet notes on our website, researchworks.net, as well as a link to the paper as well. And remember, there's a CPD form there that you can fill out if you want to use this as part of your CPD record. We're really happy to help you with that whole process.
Yeah. Terry, it was such a privilege to talk to you today. Thank you for your time and for your knowledge. And to everyone else, we will speak to you next time.
Yeah, speak to you next time. Thanks, guys. Bye,
Terry.
Terry.
Thank you so much.
Bye.
wonderful, Terry.
Thanks, Terry.
My goodness.
That was fantastic.
Oh, learned so much from that. Thanks for recording on your end as well.
We went a little bit beyond what the review article did, but it's always fun to.
That's all right.
I know. I couldn't believe how quickly time was passing.
I know.
I'm like, what? 40 minutes already?
Well, there's a lot of this stuff. I mean, it goes on and on. I mean, the research stuff is just showing us amazing things about this, and it's just we're so far behind in publishing the data, but it's we get terabytes of data from every single child. I have a team of students working on this stuff.
Wow.
Oh,
well, hopefully we can talk to you again as more publications come out. I think it's something that our listeners find really interesting and we find really interesting as well. So we'd love to talk to you more about it as they come out.
Well, and hopefully there'll be more, the Australian ACE-PDM will start up again. We'll be able to travel and
Well, the one coming up in March was all going to be in person, and that's just been moved to being virtual again.
Yeah.
So
we were looking forward to our trip to Melbourne.
We were.
Wow. That's very sad.
I know.
Already? Oh dear. Okay. Well.
Yeah. Hey, and in terms of just further research, like we've been doing a lot of the work that we're doing at the moment in the organisation that I work at, so Healthy Strides Foundation. We started that a few years ago, and it was in response to doing some of our research work. And we work with a lot. Like we seem to get most of the kids who are GMS is level 4 and 5 because we do locomotor training with them, and we support their ability to walk in gait trainers for physical activity. And we get so many children that have dystonia and dyskinemic CP. It's like probably the main group of children that we see. So we've got like lots of different ways that we can treat or even just how to modulate tone, especially if they're really, really stiff. And we know that active movement can help to modulate that. So it'd be really great to even just talk to you, at another time, perhaps about what we're seeing, because we are seeing some really great improvements in this area.
Yeah. No, absolutely. I mean, I think there's a lot to be done there. We fought very hard. I mean, I have, a lot of us have for many years to sort of try to find non-invasive treatments. And it's very hard to learn your way around dystonia. Like it makes it, because it kind of learns its way around you. And so so you can learn strategies. But it's very hard to calm it down. And in fact, a lot of, sort of prosthetics don't help you very much. It fights all braces, those, and it doesn't, it will also fight, you use things like for tremor, like weighted wristlets and stuff. And that it fights those too, right? I mean, it's just because it has full access to your normal motor system to try to achieve, its nefarious ends. But I think there is stuff. I mean, I think the role of sensory input's important. We just completed a large clinical trial on biofeedback device, vibration biofeedback. And I wouldn't say large, small clinical trial, large in the sense that it took us a long time to get it done.
They all feel large.
And there's definitely a subset of kids who do better with that. There's some electrical stimulation things that may have some benefit, but it's, we're not near really having a solution. So I'd be very curious. I mean, if you found stuff that helps these kids, oh my God, it's amazing.
Yeah, right? I think we've been wanting to sort of flesh that out a bit more and doing like single case experimental designs where we can actually, because, a lot of the time they're excluded from studies because we only look at spasticity. But when you do have them in there, like you just said in the podcast, it's not like one child with dyskinemic CP looks the same as another.
So individual.
So individual, the part of the limb, the speed of movement, the force behind the movement, the resting tremors, like it's so variable. But, we had one person in the trial who's got glutaric aciduria, I think was the cause. So she's GMS level 5 and she has so much movement. She's bigger now, so she's so much stronger. But when she does the trial, she is completely relaxed. And the carryover for mum was care and comfort. So she could transfer more easily. Respiratory, she didn't have difficulties breathing at night. So there were just, you see these and you're like, okay, there's something here. What is it? What's the mechanism? And how can we? Well,
dystonia is any kind of discomfort makes dystonia worse. So we always have to optimize the medical care. Absolutely. But I also think you're right. I mean, anxiety is a huge trigger and perception of effort is a huge trigger. The kids who are able to do so, I've sent a bunch of them things like cognitive behavioral therapy to learn relaxation techniques. which seems to make a big difference in reducing the dystonia. If you can move, I have one kid who, as he tries to walk, his foot pulls off the floor and he can't step. And we just literally taught him, trust your feet. As soon as his foot is on the ground, it'll weight bear. But it just keeps pulling. He's afraid because it keeps pulling off. So we're like, just trust it. You've never fallen, right? And so a lot of it is just, he just had to learn to trust his body because the fear of the dystonia was preventing him from walking as well as he could have, even with the dystonia, right? So there's things like that where it's so psychologically triggered. There are some genetic dystonias like the alternating hemiplegia that is psychologically triggered, but there's so much of these things are there's just a modulator of it, and it's like, that makes sense, right? I mean, a lot of what the benzodiazepines treat dystonia, they're also anti-anxieties. So
that's true. Yeah, that's true. Yeah. Well, we better go because we've got to move out of the studio in a little bit.
Thank you so much, Terry. It was so nice to meet you. Thank you.
Good to meet you. Dana, it's good to see you again. Yeah. Let's stay in touch.
Yeah, let's definitely do. Thank you so much for your time, Terry. Take care.
Thanks, Terry.
Take care. Bye-bye.
Bye.